Welcome back to the Doctor is in television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon right here in beautiful Monterey, California. Thank you so very much for joining us. I'm delighted you could be here today as I discuss one of my favorite topics of what I do all year long, and that's go on humanitarian mission trips to other countries, developing countries, and help children and babies and even some adults with unrepaired cleft lips and palates and burned hands and simple tumors and things like that. I'm delighted you could be here for this segment. I enjoy spreading the word about what Rotary does with Rotoplast, Alliance for Smiles, or with Plasticos. This past year, in the year 2018, I went on 3 humanitarian missions. I went to Cuba after the hurricanes. I went to Myanmar, and they still are having some difficulties with kind of a humanitarian crisis with the Rohingya, the Muslim or Islamic minority. And also I went to Guatemala following the volcano. There was a lot of work to be done. I think that's a pattern we see all over the world when there's a humanitarian crisis or a natural disaster. Probably much of the attention or much of the resources are taken away from social services or surgical attention for the children and babies with cleft lip and palate. And that attention and those resources are diverted away to help with the humanitarian crisis or to help with the natural disaster recovery. And certainly I think that's understood. But as I said, this year I went on 3 humanitarian missions, and I'd like to start by talking about our recent trip to Guatemala. We flew into Guatemala City, a relatively small team. I think this was only about 12 people. We had 2 surgeons, one from Philadelphia, myself, and we met up with a surgeon there in Guatemala City, a really good cleft surgeon, Milton Solis. This is a view from the hospital, and we see on day 1, what we do is we hold clinic. And during the clinic, we triage the kids and the babies. What that means is we actually sort them out and put them into groups. There are always children that we feel can be taken care of there, either by another team or by the local surgeons and nurses. And oftentimes we'll see children and babies that are in need of an intensive care unit or they're kind of sick. And so we usually discourage those babies and children. However, or discourage them from having an operation on that trip, and we'll usually try to get them to the United States if they need an intensive care unit or defer them to another clinic later that year. So the hospital there that we operated in, they were very hospitable people in Guatemala. We were delighted to be there, and they were delighted to have us. As I said, there was an earthquake earlier this year in Guatemala, and a lot of the attention that normally, and a lot of the services and energy normally directed toward the children and kids was diverted towards recovering from the volcano. And so we can see some of the volcanic range there outside of Guatemala City. So we fly into Guatemala from Houston. We set up in Guatemala City. They were kind enough to let us use this hospital to St. Lazarus. It's a public hospital there. And we triage the children and babies during the first clinic day. We typically see children with unrepaired cleft lips and palates. We see some burned hands. This is a little girl who has congenital ptosis. Ptosis is a descriptive term for the eyelids. Some children are born without satisfactory muscle to be able to lift up the eyelid. That's called ptosis. Sometimes people call that lazy eye. There can be a number of causes of ptosis. Of course, this can happen in the United States as well. Older people sometimes get lash ptosis, leading to visual field obstruction. A lash ptosis is when there's so much extra skin of the upper lid that the redundant skin rests upon the eyelashes, and it's difficult for the older adult to hold the eye open. Oftentimes there's visual field obstruction. The amount of light and the image that's coming into the eyelid is obstructed. That's called lashtosis. In older adults, too, the levator muscle that lifts up the eyelid can get weak or torn or have a neurologic problem, and so the activity of the upper lid is insufficient. That's called ptosis. So sometimes we operate on these children and babies with ptosis, or we can do a cleft lip repair. Here's a baby with an unrepaired cleft lip. We can see that that's a complete cleft of the left lip. What that means is that the cleft in the lip goes all the way up into the floor of the nose. That's called a complete cleft lip. And it can happen on the left side, it can happen on the right side, and sometimes it even happens on both sides. That's called a bilateral cleft lip. But for this boy, this young baby, as we can see, it's a complete cleft of the lip on the left. It just extends up into the nose. And of course, sometimes we see a cleft lip that's just barely malformed, just part way up the lip. That's called an incomplete cleft. And sometimes it goes all the way up. Now here's another baby with a complete cleft of the lip on the right side, as we see here with the mother. And this is a very common congenital anomaly, malformation that happens in the Hispanic population about 1 out of every 1,200 births. 1 out of every 400 births. The most common incidence of clefts is outside of Shanghai, China. 1 out of every 1,200 babies born outside of Shanghai, China has a cleft, either a cleft lip or a cleft palate. In the Hispanic population, it's about 1 out of every 400 babies. In particular, on the western side of South America, in Chile and Argentina, it's about 1 out of every 400. In European countries, European nations, and in Canada and the United States, among Caucasians and Europeans, the incidence is about 1 out of every 1,200 births. The lowest incidence of any continent on Earth is in Africa. It's about 1 out of every 2,000 births in Africa. So some ethnicities and some groups have certain anomalies and certain diseases and certain predispositions towards illnesses or sicknesses that other countries don't, and it can be the other way around. For example, cystic fibrosis is very common in European and Caucasian populations. However, it's less common in the African population. However, sickle cell anemia is mostly confined to the African population and far less common in the European population. So again, I described the incidence of clefts outside of Shanghai, China being about 1 out of every 250 births, the western side of South America 1 out of 400 births, Europeans and Canadians and United States Caucasians about 1 out of every 1,200 births, and again in Africa about 1 out of every 2,000 births. So here's that child. As you can see, this is a complete unilateral cleft. It goes all the way up into the nose. And what's happening here is, of course, the teeth and the premaxilla is exposed. Those teeth and the alveolus are exposed to the air. They tend to get dried out, and it's not good for the health of the teeth. You can have a cleft palate along with a cleft lip, or you can have a cleft palate alone, or a cleft lip alone. The cleft palate, of course, is a split or division in the roof of the mouth. And there's the hard palate and the soft palate. It can be just the soft palate, or it can extend from the soft palate into the hard palate. Now, as we see here, the teeth lay upon or erupt from, they rest upon a ridge called the alveolar ridge. When the cleft extends through the alveolar ridge, then there's a split in the dental arch. So the teeth are misaligned, the palate can collapse, that arch of the teeth can collapse, and that's oftentimes why in the United States we'll have a cleft palate team, and there'll be an orthodontist as part of the team, an oral surgeon as part of the team, as well as a speech therapist, an ENT doctor, plastic surgeon, of course, some maternity nurses or pediatric nurses. It's a very complicated, complex, multifactorial issue, and multidisciplinary field, and the clinic is covered by different specialties, not just plastic surgeons. So there's the baby at about postoperative day number 2. you can see that that cleft had extended up into the floor of the nose, and that's the repair of the cleft lip, as you can see. The mom is very delighted. Something that I wanted to clarify, sometimes when audiences see these pictures, they'll think that during the surgery I missed the midline, or I somehow made a mistake or miscalculated, and the scar for the cleft lip ends up on the side or under the nostril instead of in the midline. Actually, that's intentional. The Cupid's bow is that part of the vermilion cutaneous border, the white roll that slopes gently up and then down and then up and then down. That's the Cupid's bow, in other words, mimicking for the bow and arrow, Cupid's bow, and the philtral columns extend up from the high points of the Cupid's bow, extend up into the nose. Studies indicate that when we lay the scar right on that philtral column, it tends to blend in very well. So we're not trying to put the scar or the incision right in the midline. We're trying to line up the scar right on that philtral column, emanating from the high point of that Cupid's bow into the nose. And that tends with time to fade quite well, and it actually mimics the philtral column itself. So a baby with a unilateral cleft lip, we want that scar to go up the philtral column, because typically a baby with a unilateral cleft lip will have the normal philtral column or normal ridge, and then the scar will be corresponding on the other philtral column or ridge, and then it tends to give the appearance of symmetry and harmony and balance. Now, when a baby has a bilateral cleft lip, then there's two scars. And again, we try to lay those scars and mimic the philtral columns, extending up from the Cupid's bow. Once again, if you think of the Cupid's bow like the bow and arrow, it's that bow. There's a gentle slope upward to a high point, and then slightly downward to a low point, and then upward again, and then a gentle sloping towards the corner of the mouth. That's the vermilion cutaneous border or white roll, and the Cupid's bow is right in the middle. And you know probably from fashion and beauty and models, a very pronounced Cupid's bow now is in vogue, and it's very attractive and very beautiful. There's something called a Paris lip that we try to mimic with injections of collagen and filler, and by plumping up the lip and accenting that vermilion cutaneous border. So going back to the baby or the child with ptosis, what we do is harvest some fascia. And the fascia is that collagen lining on top of a muscle. Sometimes in this country we'll use little silastic bands or little silastic tubing, an artificial substitute for fascia. But in this particular case, we go to the lateral thigh and we harvest some of that connective tissue. And what we do is we connect the eyelid, the tarsal plate, to the frontalis muscle in the forehead, because this baby, this child, even though she cannot elevate her eyelid very well, still her eyebrow can be lifted. That's because the frontalis muscle in the forehead is innervated by a different cranial nerve than the eyelid. And so what we're doing is creating a sort of rope and pulley system. We're using this fascia to connect the tarsal plate of the upper lid that's not being elevated very well because of the levator muscle, and we're tunneling it under the eyebrow and under the skin to the frontalis muscle that does work well. And so the child will quickly learn to lift her eyebrows and raise her forehead and then raise the eyelid itself. It's a type of kind of rope and pulley system. So that's a type of reconstruction and correction of congenital ptosis. Just very briefly, ptosis, when it has another cause, for example, too much excess skin of the upper lid, we can trim the skin, remove extra skin. When the levator muscle is loose or lax or torn, we can go in and shore up that muscle. Sometimes we repair it. It can even detach in some type of injuries, and sometimes what's called the aponeurosis, the levator aponeurosis, can get very attenuated and stretched out, and that can be a type or one cause of ptosis. And so we re-advance that levator muscle to the tarsal plate to restore the ability of a person to lift up and elevate their eyelids. So that's a relatively common operation done in children, especially in the United States. Cleft lip and palate we oftentimes will do here in the United States as well. So I'd like to teach a little bit and distinguish between a cleft lip and a cleft palate. As I said, the cleft lip is what you can see. That's on the outside. I think that's reasonably straightforward. Behind the lip, of course, is the ridge called the alveolar ridge, where the teeth erupt from. The roots of the teeth lay upon that alveolar ridge, and when there's a cleft of the palate, that's of course the roof of the mouth. That can involve the soft palate, that's the flutter valve that's way in the back of the throat, that the uvula, or the little tongue, the little fleshy part that sits in the back of the throat on the soft palate, that serves as a kind of flutter valve. And what that does is help to redistribute the airflow in between the mouth and the nose. It's very important for certain phrases, such as cookie and Coca-Cola. There are these phrases or word sounds called fricatives and plosives, where the flutter valve is very important. The soft palate needs to go up and touch the back of the throat. That's called velopharyngeal competence. When there's a cleft of the soft palate, the baby will typically have a velopharyngeal incompetence, or VPI, and that in that type of instance, the speech can be poor because the baby cannot distribute the air flow properly in between the nose and the mouth. And so the speech is not always clear. So again, a cleft lip is what you can see. For example, here's a mama holding her baby with I think this is an incomplete cleft of the left lip. It extends almost to the floor of the nose, but not quite into it. So that's that's an incomplete cleft lip. So again, as I said, the palate can have a cleft as well as a lip, or they can be separate. Now here's a baby. I took this picture to demonstrate that the nose of a cleft lip child can be distorted. As that cleft continues into the maxilla, which is the upper jaw, and up into the nose, the floor or the nostrils rest on bones that are of different projecting heights, or the anterior vector is different, and hence the nostrils can be different, the alar rims can be different. So during that cleft lip repair, we'll oftentimes do a tip rhinoplasty and at least get started to straighten out that septum, straighten out the columella, that's the middle strut in between the nostrils, and at least get started to straightening out the deviated nose and try to bring some symmetry and reconstruct the nostril floor at the same time. So as we see here, here's a complete cleft of the left lip. And it's interesting for me when I look at these pictures, I'm reminded of some of the first modern cleft lip repairs. We can see that the Cupid's bow is there in the philtrum, but it's just that it's misplaced and it's kind of crooked. So the modern way to repair a cleft lip like this is to rotate that flap, rotate the philtrum down so it's balanced and has some symmetry and harmony, and then advance the lateral segment from the side where the cleft is and bring these two segments together. Also trying to straighten out the nose. Sometimes I am asked, why is it that these babies can get a cleft lip? Is there something in the water? Is there just something that goes wrong? Well, it's very interesting to me that on day 28 in utero, and keep in mind, that's before most women even know they're pregnant. So day 28 in utero, the facial segments are designed to fuse. The Meckel's cartilage that forms the jaw comes from the side to unite. The maxillary segment, or the upper jaw, they roll in from the right and left. And this is, again, at day 28. It's the sort of, almost like a zygote. And then from the notochord, from the frontal nasal process, the central portion rolls down with the nose and the philtral column to unite with the lateral segments. And that has to be timed just almost perfectly. And if there's just something askew in the timing, if one segment arrives there earlier or one segment arrives late, then there can be a cleft lip as we see. So again, that's on day 28. Once it's in the congenital pool, once it's in the DNA pool in certain ethnicities, it's more likely to pop up. The cause is really multifactorial. If there's hypoxia for some reason or low oxygen tension across the placenta on day 28, a cleft can occur. Some certain medications such as phenytoin, dilantin, if that's on board, that can bring about a cleft lip. It's probably something related to folic acid deficiency or metabolism. Folic acid deficiency, of course, in this country can lead to spina bifida, spinal cord problems, etc. So it's pretty clear that families that have a tendency towards clefting, cleft lip and cleft palate, if the mother takes a folic acid supplement, probably the incidence of cleft can be diminished. But again, it happens on day 28, so a woman needs to start the folic acid supplements even before she's getting pregnant or very early on. There's the baby with the attentive mama. I think that's on about day 3 after the cleft lip repair. So what happens at the hospital? And there's that baby. As you can see, there's a sort of curvilinear or short incision under the nostril to help rotate in that left nostril, help reconstruct the nasal floor. We're reconstructing the philtral column and Cupid's bow. And there's a little incision under what we call the columella. That's the middle portion in between the nostrils. So what we're trying to do is restore some balance and symmetry and harmony with the cleft lip repair. And we're doing a little bit of a rhinoplasty as well, a cleft lip repair. Excuse me, a rhinoplasty. When we do the cleft lip repair, we're doing a little tip rhinoplasty. Sometimes I'm asked, in this country, why don't we see babies walking around with unrepaired cleft lips and palates? Well, that's because they get their surgery when it's needed at a young age. Now, in this country, with a cleft palate team, whether the plastic surgeon is in private practice or at a university or at an HMO or something like that, there's oftentimes other doctors around to help. As I said, orthodontist, an oral surgeon, an ENT, a dentist, nurses that can help teach feeding, because these babies with a cleft palate, they don't suckle very well. In addition to having problems with speech, they can't make that vacuum to suckle well, whether it's from the baby's breast or from a bottle. And so they're slow feeders and they can have low weight gaining. So in this country, a baby may get about 5 operations between the age of 3 months and say 16 years. We can do the lip, we can touch up the nose, we may do a bone graft to the alveolar ridge that holds the teeth, we can do the palate repair, we may do speech therapy, we may do a secondary rhinoplasty, and sometimes we even adjust the jaw and bring the jaw forward. That's called a Lafort procedure. So there's a baby on about day 1 or 2 after surgery. You can see where the incision lays right upon that left philtral column. We've restored the Cupid's bow. We've brought a lot of balance and harmony to the nose. And so I think that's, the baby's swollen here and a little bit discolored and probably is anxious to get into the shower or have a bath. But that is a typical appearance of a cleft lip and nose repair on about day 2. And there's the happy, grateful mom. And universally, I would say, when we go to these developing countries to do cleft lip and palate repairs, they're very grateful, and we get a good feeling from it. It's one of my favorite professional activities I do all year. I love to do those operations. We love to help the babies and children. We love to help the families that can't get the help otherwise. They're very grateful to Rotary, very grateful to our American team. And for us, there's very little paperwork. There's very little in the way of electronic medical records. There's no insurance. There's no money involved. Nobody gets paid. Almost always they say thank you, and it reminds us of why we all went to medical school. We get to really help the babies and children and practice our craft, and very little administration, very little paperwork. And so it's really a joy for us to go to these countries and work with the doctors and nurses there and be treated with such hospitality. Again, that was in Guatemala City. One of the other trips I made this year, a humanitarian mission, was to Myanmar. And Myanmar is a very wonderful country, very peaceful people. They were very hospitable. unbelievably grateful to us, wonderful doctors and nurses working with us. Uh, I was surprised at the number of babies and children that we saw in this part of the country, in Myanmar, at the new capital. I think there were over 100 children and babies that came to our clinic on the first day with an unrepaired cleft lip and palate. Really, there's a great need, and as I said, very warm people, very hospitable, very grateful to have us there, and they were delighted to be working with us. And we got to do some teaching, we got to do some information sharing. So here's a baby getting ready to go to the operating room in Myanmar. As you can see, that cleft on the right doesn't quite go up into the nose. So I would classify that as an incomplete cleft of the lip on the right. And so the repair overall is essentially the same. What we want to do is advance that lateral segment and rotate the segment with the philtral column. So that's an advancement rotation repair. Some people call this the Millard repair, named after Ralph Millard. So there we see the repair on the table. We did some work on the nose. Now again, I'm not aiming to have that scar or incision midline. I'm aiming to have that symmetric with the left philtral column because we want to restore the Cupid's bow. We want to restore the symmetry of the philtral columns, and we want there to be some balance and harmony and symmetry in the lip. Now, this is not only a skin operation. We reunite and reconstruct the muscle because it's important as the baby matures that the lip move well as just have an acceptable, pretty appearance. We want the baby to grow up to have good speech and to be able to suckle and eat well, and of course to grow up and be a good kisser. We want children all over the world to have that joy of being able to kiss properly and romantically, even though they were born with a cleft lip. Now here's another baby from Myanmar. I would call this an incomplete cleft on the right. Again, the cleft does not quite extend all the way up into the nose. So what we need to do is advance that lateral segment, rotate the segment with the philtrum, and we also do some nasal work. And again, in this country, we have the rule of tens, where the baby has to have a hemoglobin of 10, weigh about 10 pounds, and be about 10 weeks old. That's about the safe, proper time. I would say the most accepted standard of care, proper time to do the cleft lip repair is to follow the rule of tens at about age 10 weeks. I was about to say that Ralph Millard, a famous plastic surgeon who was in Miami, was working in Korea as part of in a MASH unit in the Korean War. And one of the Korean mothers brought their baby to him when it got out into town that there was a plastic surgeon helping to reconstruct and repair the injured American GIs. One of the Korean babies with their mother showed up at the clinic, and he had in his tent a photograph of the cleft lip of the baby, and he hung that in his tent, and he stared at it, and he studied it, and then it came to him that all the parts were there, but they were just in the wrong position. The philtrum was mal-rotated. It needed to be rotated back. The lateral segment was there, but it was wide. There was a cleft. And so he came up with this more modern repair, the advancement rotation repair, sometimes called the Millard repair, to advance and rotate segments to repair the cleft and bring the muscle together and work on the floor of the nose and bring some symmetry and harmony to the nose, etc. So that's a more modern cleft lip repair that we do now. For a cleft palate, of course, that's a totally different operation, but we want to close that space in the roof of the mouth, whether it's the hard palate or the soft palate. And here we see the baby on the table right after the repair. We see the philtral column. We see that nice philtrum. The baby looks like she's gonna grow up with a very full pout. Cupid's bow is restored. You can see I did some work on the nose as well. And so that's right on the table, cleft lip repair of that right unilateral cleft lip. As I said, the cleft lip can occur on one side or both sides. Here's another baby Another child with an incomplete cleft, as you can see there. The nose isn't too bad. The split or cleft does not extend all the way up into the floor of the nose. Now, I can't tell from this picture if the alveolar ridge is involved. I suspect, it looks to me like there is a slight cleft in that hard palate or alveolus. Again, the alveolar ridge is where the teeth rest. The hard palate is the hard roof of the mouth. The soft palate is that fleshy part back towards the throat that serves as kind of a flutter valve for speech. And also these kids are unable to make a vacuum, and so they get ear infections. They can't drain the eustachian tube as well. They have dental problems. They have a change in the flora of the nasal pharyngeal environment, and so they have some probable increase in chance of infection, etc. And there's a baby. I think this is just switched around. I think the negative got switched. There's the baby with the repaired cleft lip. You see I balanced out the nose as well. We see the philtral column on the side, not in the middle. Cupid's bow is restored. And so there's the baby on the table right after repair. And these kids in Myanmar lined up, as I said, over 100. And again, there's a preoperative picture. There's the baby in the holding area with the very attentive mother. And again, these parents, these families are very grateful for the Rotary team, for the American team. We work with their doctors and nurses. And there's the mom with the baby on about day 3, post-op day 3, repaired cleft lip. They're very grateful. So what we do with these babies, we keep them around in the hospital and tend to their wounds, tend to the incision, tend to the sutures. We keep the cleft lips and palates overnight. Sometimes the cleft palate kids stay around an extra night. They get antibiotics if they need to. And there's the baby standing up, of course, on the mother's knee with a repaired cleft lip. And we did some work on the nose as well. Very grateful, very hospitable people. And there's the mother with the baby that I just showed. And I think the mother standing next to her has a baby with an unrepaired cleft palate. And so, as I said, a cleft can come involving the cleft lip or the cleft palate or together. Very grateful people, very peaceful people. It was very fascinating to us to see every once in a while adults will come into clinics. I've done surgery on unrepaired cleft lips on people who were over 50. And it's really fascinating to us. I recall one man in Bolivia. We did a cleft lip repair on him. He was about 55 years old. He went home and he came back to our clinic and told us that he went home and kissed his wife for the first time. Really quite remarkable. So there's that gentleman in Myanmar with a repaired. He's about 45, as I recall. As you can see, once again, we try to restore the balance and symmetry to the nose. And that incision, that scar, lays right in the philtral column on the right, and we've restored the Cupid's bow, etc. Very rewarding to work with a person with an unrepaired cleft lip or palate that's gotten to be this age, 45 or 50 or 55, and never had an operation. It's very rewarding for us to be thanked by these people after doing the surgery, in addition to repairing the babies. Now, again, here's a cleft lip on the left side that extends all the way up into the floor of the nose. So that's a complete cleft on the left of the unilateral cleft lip. As I recall, this baby also had a cleft palate extending posteriorly, of course. Now the question becomes, do we ever repair the cleft lip and palate at the same time? We do that sometimes, especially in these developing countries. We're trying to get everyone done, all the babies that we can and all the children that we can. And there's the baby with a repaired cleft on that side. That little white gauze on the side of the nose, I use that sometimes as a bolster to help me put the help me keep the cartilage where it belongs. I move the cartilage of the nose around and transpose it and release it and transpose it back to where I like it to be. And sometimes I use a little bolster inside the nostril or even on the outside that stays there for about 5 days. So that's the function of that. Very grateful father. And you can tell from the little boy making eye contact. What's fascinating to me is that these children have totally normal intelligence. Just because they have a cleft doesn't mean that they have any less intelligence. Some of the reputation that these children have gotten over the years who have cleft palates, especially, sometimes a cleft lip, sometimes they get a reputation for not being normal intelligence. It's really because they're afraid to speak up. They don't speak well. Sometimes they get bullied. Sometimes they're ridiculed because they can't make the same sounds as their classmate. And so we think it's really important to give the baby an ability to speak well. So we try to do the cleft lip at about age 3 months. The cleft palate is typically done in this country, anywhere from 9 months to 13 months. We want to bring those muscles together and bring the soft palate together just before the baby starts to speak. Here's a couple other grateful parents, and I should say that must be the mother, and I think that's the sister and the aunt with a young man. I think that's a cleft palate repair. He's borrowing my drumsticks. Of course, he was fascinated with that. And so they're very grateful people. And of course, many of the adults and some of the children have a natural treatment for their skin to improve their collection. It's a natural plant extract that comes from a tree and a plant. I think that's indigenous to the Southeast Asia, and it works as a type of exfoliant. It works as a skin care, and they'll oftentimes apply it to their own cheeks or the baby. Even the baby's skin helps to keep their skin looking fresh, helps them to keep their skin looking youthful and smooth. Very happy. And as I said, it's mainly a Buddhist country, very peaceful people. They brought us to a Buddhist temple one day, and we all felt this sort of aura and feeling of peace, really beautiful, very hospitable, very warm people. And the picture of the roof there, this is the new capital in Myanmar. Of course, the country used to be known as Burma. Now it's Myanmar. You've seen it in the news lately because there's been a big emigration of the Rohingya out of the country to nearby Bangladesh. Very peaceful, very warm, loving people, very hospitable. They treated us so well, and the nurses and doctors worked with us, and we were delighted. Again, that was 2 of the 3 trips I went on this year. In 2018, I went to Cuba after the hurricanes and worked with the Cuban doctors and nurses. More of an information exchange trip. We worked together. I came home and then went to Myanmar and came home, and then I went to Guatemala. It's a lot of missions to do in 1 year, but it's very rewarding, and I'm very grateful for that opportunity to Rotoplast, that's the Rotary Club, and Alliance for Smiles, or Plasticos. If you would like any more information on these humanitarian missions to take care of children with unrepaired cleft lips and palates, you can go to my website, drmorwood.com, and check it out, or call my office, 831-646-8661. Once again, I'm Dr. David Morwood. I am a board-certified plastic surgeon right here in beautiful Monterey, California. We're going to take a very brief pause for a very good cause. I hope you'll stay with us. Hello, I'm Dr. David Morwood. I have over 25 years experience in plastic surgery. One of the common goals I share with my patients is that they look natural after their facial rejuvenation.
Dr. Morwood made me feel really comfortable. His staff is phenomenal. Going into his office is always a great experience.
Call or click today to learn how our combined approach of art and science can enhance your natural beauty. Hello, I'm Dr. David Morwood. I have over 25 years experience in plastic surgery. A smooth, firm neckline is a universal sign of beauty in both women and men.
Dr. Morwood not only helped me regain my confidence, he helped me achieve the best version of me.
Call or click today to learn how the natural neck lift can rejuvenate your beautiful neck and jawline.